Today's talk, I've kept it very basic and simple because I wanted to discuss some basics of growth first before we learn, how the growth hormone therapy works for us and what are the pros and the cons. Because I think not just for growth hormone deficiency, even if you're talking about CAH or any condition which requires a long-term treatment, eventually, if your child is growing well, you know that the disease portion is under control. So eventually, as parents, we all want to see that the growth of our child is going fine. And I think growth charts are the basic thing which are going to help us in knowing that, right? So before we learn about growth hormone therapy in a bit detail, I'm going to talk about growth in the next few slides. So we always believe that growth is a dynamic process, right? It begins in utero as soon as the zygote is formed, and the active growth is going to end with the pubertal development. So once a girl starts her menses or a boy achieves a testicular volume of 20-25 ml, that is the time when they will stop growing. So otherwise, throughout the whole childhood, growth is going to be a dynamic process, right? Now, there are different phases of growth. We have all gone through these different phases of growth. The first is the infantile. So the first 2 to 3 years of life, the baby is going to grow very fast. So to give you an example, a child is born with a birth length of around 50 centimeters. And by the end of 1 year, the child is almost 75 centimeters, like the average. So the child has grown about 25 centimeters in the first year, right? So by the end of 2 or 3 years, the child has gained about 35 to 40 centimeters height. So this is a phase of very rapid growth, and that is the first phase, which is called the infantile phase. After this phase is over, they will kind of settle down to a normal growth velocity of 4 to 6 centimeter per year. So you must have heard the doctors talking a lot about growth velocity. So what is growth velocity? Very simple. How many centimeters would you grow in a year? That is called a growth velocity, right? Normal in the childhood phase being 4 to 6 centimeter per year. So somebody who is on the lower percentiles for the growth chart will grow at around 4 centimeter per year. Somebody who's on the higher percentiles will grow at around 6 centimeter per year. But if somebody is growing less than this, then that is called a faltering growth velocity or a poor growth velocity, right? And then once they hit puberty, right? So remember, puberty is not periods. So many of the kids confuse puberty as periods, but puberty is the transition phase, right? From being a child. I mute again. Right. So it is the transition phase from childhood to adulthood. The whole phase lasting 1.5 to 2.5 years, and it again varies a lot. So that whole phase is called the puberty, right? In puberty, especially in the girls, from start of breast enlargement to periods, they would gain about 15 to 20 centimeters height on an average, and boys will gain about 20-25 centimeters height. Now, remember, girls tend to go into puberty earlier. They will have their growth spurt earlier, and they will finish earlier. Boys tend to, in general, go into puberty a little later, and they have their growth spurt in the later half of puberty. And therefore, the boys in the family, say if you talk about a family, a brother is usually taller than the sister in the family, right? Because the whole place, until they hit puberty, you might find that the growth of the sister and the brother is going fine, but after that, you will notice significant changes. And various hormones play an important role in all these different aspects of growth, right? So in the infantile phase, what were the intrauterine factors? Were there any placental factors, any maternal malnutrition which was affecting those? Then immediately after the baby is born, what is the nutrition like? And definitely your thyroxine and growth hormone. So for the first 3 years of life, these are the factors which play a very important role in the growth of a child. In the childhood phase, till they hit puberty, it is mainly your thyroxine and growth hormone, along with a good nutrition. right? So many parents ask, ma'am, if I improve the nutrition, is my child's height also going to improve? So remember, we always tell them that eating healthy, exercising, having a good lifestyle is very, very important. But if your child's weight is in the normal ranges, pushing the weight further is not going to help with the height, right? So unless your child is severely malnourished, you provide them nutrition, growth also improves. So again, nutrition plays a very important factor along with your hormones, which are thyroxine and growth hormone. And once the child starts puberty, it is primarily your sexual hormones. So estrogen in the girls and testosterone in the boys, along with your growth hormone and thyroxine, which will cause a pubertal growth spurt, finally causing cessation of growth. Right. So I hope all these three phases of growth are any issues with my sound? Am I audible?
The sound is fine. I think it's on that person's side. Go ahead.
Okay. Right. So any issue with any factor in any of these phases can lead to poor growth, right? So if we know about the different phases, we are able to find out where things are going wrong so we can correct them accordingly. Now, a bit about the growth charts, because this is such a nice visual tool. It will tell us how my child is growing, and it is going to pick up growth failure at its earliest, right? So we always urge the parents, we always urge the school teachers also to start using the growth charts in their practice. And these are the Indian Academy of Pediatrics growth charts. 0 to 5 have been merged with 5 to 18. So 0 to 5 are the WHO growth charts, which are used worldwide, those the international standards. And then the 5 to 18 are India-specific growth charts, which have been merged for the sake of ease. So the upper portion you can see is the height, which we always measure in centimeters. And the lower portion is the weight, which we measure in kilograms. And if you're looking at specifically the younger kids, we have these 0 to 5-year growth charts, right? Wherein the lower border, that is your x-axis, is age in months. Here you have got 3 columns. So the topmost is length until the age of 2 years and then height. The middle is the head circumference and the lower is the weight. Always remember, we are going to use boys blue, girls pink. So that has been a color standard that has been adopted internationally. So what are the basics of growth charts? There are 2 axes. The bottom one is the x-axis, which is age in years, or it can be age in months if you're using the younger growth charts. And the y-axis will record the change in whatever reference that we're looking at. So whether it's the height, whether it is the weight, or whether it is the body mass index, right? So very, very important that we are getting the height measurement correctly. So growth charts don't just tell us about how your child is growing, but if your child is on any kind of treatment, how is the treatment faring for your child? Whether the treatment is under control or not, those are also the things that you get from the growth chart. So always make sure that your child is plotted on the growth chart every 3 to 6 months. Another very, very important aspect as a clinician for me or for any pediatric endocrinologist would be to get the bone age. So bone age is almost like a part of the clinical examination for us because it will tell us the correlation between the skeletal maturity, so how my bones are growing inside, as compared to what my actual or chronological age is, right? So it also gives me an idea of the remaining growth potential. And if again somebody is on any kind of treatment for short stature, it helps in monitoring of the therapy also. So what do I mean by that? So again, this is something that we very, very commonly see in our practice. So if you look at the bone age on the left side, what we see is that the bones are open. I hope everybody gets what I mean when I say that the bones are open. So that means there is a gap between the 2 bones as compared to the X-ray on the right side where all the bones have fused and the gap has disappeared. So your child is going to grow only until the phase where there is a gap between the bones. Once the bones are fused, then your growth hormone is also not going to work, right? So if any parent is concerned about the height of a child, preferably they should go to the clinician before the puberty starts, so before breast enlargement starts in a girl, because once the puberty starts, the bones are all going to rapidly fuse, and then even the therapy may not work as well, right? So always make sure that if you are concerned about the growth of your child, please see your clinician earliest, and then maybe, the clinician will decide whether the child needs any treatment for the short stature or not. But this X-ray is a very clinical, common tool that we use in our practice. We also use this as a monitoring tool. So we'll be doing it every maybe 6 months to 12 months when somebody is on growth hormone treatment or when somebody is on treatment for precocious puberty also. So how do we investigate growth failure when you go to your doctor? Or rather, when do we investigate, right? So if you're continuously growing below the target height, so you have a genetic potential, so you should be growing according to your family's genetic potential. But if the growth is persistently below that, or you are growing fine, but suddenly you have now started faltering. So on the growth percentiles, if your graph is now falling below, or the growth velocity is less than normal. So for a child, we talked about the growth velocity of 4 to 6 centimeter per year. If your child is growing less than that, then these are the kids whom we want to investigate to find out what is the cause for the growth failure. So talking of percentiles, right? So crossing of percentiles, the child was growing fine, now the child is faltering, or the child has always been persistently below the third percentile. So these are the kids we want to definitely investigate. And how does a doctor do that? We would do a thorough clinical examination to look for any pointers of short stature, because we know that there could be sometimes certain genetic syndromes, right? Certain genetic things associated with short stature. We would do this X-ray of the left hand for the bone age, certain blood investigations to find out, more importantly, to rule out the other causes, right? The kidneys are working fine, the liver is working fine, the thyroid gland is working fine before we go for the specialized test for growth hormone deficiency. Remember, if you go to a lab, like and say, my child is short, please get, somebody has read on the Google, they'll just go and say, please do the growth hormone levels. They are of no use in diagnosing growth hormone deficiency. We need to do those specialized stimulation tests. Like in CH, sometimes we do the ACTH stimulation test. Similarly, for growth hormone deficiency, or for anybody whom we want to diagnose a growth hormone deficiency, we would do a clonidine stimulation test. So that is basically, you would take multiple blood samples. So do not do random growth hormone levels. If somebody has done it by mistake, do not worry in interpreting those random growth hormone levels. We might often do a karyotype in the girls, especially because we want to rule out the 45XO, that is a Turner syndrome. And definitely if the child is nearing the pubertal age, we want to go for sex hormone evaluations. When do we give growth hormone? There is a whole list of FDA approved indications and non-FDA approved off-label indications that we are using growth hormone now, like growth hormone deficiency, Prader-Willi syndrome, the short for gestational age baby. So they were born short. We were expecting them to have a catch-up. We'll talk about all these in a bit detail, and then we can, have the Q&A session, and then Turner syndrome and other genetic malformations. So these are FDA-approved indications of growth hormone therapy, wherein long-term studies have been done to show the effectiveness of growth hormone therapy along with its safety profile also. There are many other conditions, where we are using growth hormone off-label also, where we are not able to find out the particular reason for the short stature. And that is going to be very, very individualized, and strict monitoring is also required in those cases. So let us just go through briefly the more commoner conditions, because you had told me to talk about which growth hormone specific conditions do we use growth hormone. So the best response we get is in growth hormone deficiency. So child does not have growth hormone, the child is not growing well, whatever the reason be, you give the child growth hormone, they are going to respond the best, right? So the left child, the child has been born with a growth hormone deficiency. It can be sporadic or it can be a familial growth hormone deficiency where certain genetic mutations are present, which are causing, so these are the congenital forms of growth hormone deficiency, or they can be acquired. where somebody develops, say, a craniopharyngioma in the pituitary gland, and that is pressing the pituitary gland and causing it to malfunction, right? So now growth hormone is not there. So it's an acquired form of growth hormone deficiency. So these are the kids in whom growth hormone treatment is going to work the best. They are going to respond very beautifully. And again, remember, in growth hormone deficiency, the earlier you start, the better the response is, right? Chronic renal failure, right? So this is another approved indication for growth hormone therapy, because we know that CKD per se can have short stature. So about 30 to 50% of them have severe short stature. The reasons can be multifactorial. If you talk about the growth hormone aspect, usually there is some resistance to growth hormone action. Preferably, you start the treatment before the child gets a transplant, and when you're noticing that the child is having a declining height velocity. So we have so many of our kids of CKD who are on growth hormone treatment now, and they are definitely catching up on their height. And so when they get a transplant, the quality of life is definitely much better. Turner syndrome. So as I was talking earlier, the reason why we get a karyotype, when we talk about karyotype, I'm sure everybody of you know what a karyotype is, to just get a basic mapping of your 46 chromosomes, right? In Turner syndrome, this happens in the girls, wherein instead of the 2X chromosome, one is missing. So you have 45 chromosomes and only one X chromosome, right? These are also the kids who are going to present to us with sometimes just short stature, and they would require growth hormone treatment at much larger doses. Right? So this is another subset of kids who come to us with short stature, or they may just go to the gynecologist, with complaints of not having periods. And then you do the karyotype and they turn out to have Turner syndrome. Prader-Willi syndrome, right? So again, genetic mutations are happening. Many of these kids are short because of growth hormone deficiency. But remember, here we are using growth hormone not just to gain the height, but growth hormone has a lot of metabolic benefits also. So it helps in improving your bone density. It helps in improving your muscle mass distribution, in decreasing your obesity, in improving your body composition also, right? So in Prader-Willi syndrome, we have started using growth hormone as young as 3 to 6 months with strict monitoring. And remember, a sleep study is always a must, because we do not want to have any obstructive respiratory symptoms before we start growth hormone treatment. But here, primarily, growth hormone is used for its metabolic benefits rather than for gaining of height, which definitely does happen though. SD and IUGR, I think we are increasingly seeing these subset of patients. So this is short for gestational age or kids with intrauterine growth retardation, right? So in the NICU, so many of preemies, so many of IUGR babies are now being saved. So we are having babies born at 28 weeks, 29 weeks, or babies born at full term with some complications, and therefore the baby ends up with a birth weight of 1 to 1.5 kgs, right? Now, remember, 80% of these babies will have a catch-up growth by 3 years. But there are still 10 to 15% of the babies who will not have a catch-up growth, and they will always be on the lesser percentiles for their genetic potential, or even maybe less than the third percentile. So even in these kids, earlier you pick up these kids, you can offer them growth hormone treatment, and they are going to start having the catch-up and be in the normal percentiles for their target height, right? So remember, again, earlier we treat, better the results. So if you have any kid who has been born IUGR, who on the growth chart is failing to have a catch-up growth, they also can be offered growth hormone treatment. Idiopathic short stature. Idiopathic माने जब कोई reason नहीं मिलता है तो हम बोलते हैं it is idiopathic. There are definitely reasons for that. But हमने जो basic हमारे investigations करे हैं, all of them have turned out normal. So whether to treat them or not treat, right? So essentially these are normally growing short children, right? So once you have ruled out everything, you see how they are growing, you see what their target height could be. And based on that, you take the decision whether you want to treat these kids or not. So, there are various inclusion criteria where we decide when to treat these kids with growth hormone treatment. So essentially, they are normal. but just short children who are going to end up being short adults, though the parental heights are normal. So they can be offered growth hormone treatment now, but they have to take growth hormone treatment for longer periods of time to have better results. Right? Now, remember, whenever you're putting a child of idiopathic short stature on growth hormone, we have to make sure the epiphyses are not closed. So often girls, come to us at the age of 12 and 13. They've already been started menstruating since 10 and a half to 11 years. And now they have realized that the child is not growing since last 1 year, right? So if the epiphysis, the bone gap is already closed on the X-ray, then even growth hormone therapy is not going to work, right? So make sure that whenever that is why I always keep on saying that if you feel your child is not growing well, or if you feel that the child is short, always seek the help of your pediatrician, because let them decide whether the child is growing fine or not, and whether the child needs any treatment for the same or not, right? Now, based on different conditions, the response to growth hormone will change. As I told you, growth hormone deficiency, you don't have something in your body, you have it as a medicine, you're going to grow beautifully, right? So similarly, growth hormone is going to work the best in kids who have got growth hormone deficiency. Either they were born with a growth hormone deficiency, or it was acquired because of whatever reason. Conditions like Turner syndrome and renal failure, they have in part some growth hormone resistance. So to overcome that resistance, we have to give slightly larger doses, and they would respond moderately, right? So again, it depends upon the duration of treatment, how early you start the treatment, and what is your bone age like, what is the nutrition aspect in these kids, how well your underlying condition is also under control. Say if you have a kid of renal failure, if the renal failure is not well managed, definitely your growth hormone is also not going to work as well, right? So how your underlying condition for which you're giving growth hormone is also managed, also has to be addressed. Younger children with larger deficit in height and more delayed bone age, that means more growth potential left, they are going to respond the best. So how do you give it? Look, remember, just like insulin, growth hormone is a protein. So if you eat the protein, it's get digested by the stomach's acidity. So that is why we bypass the GI tract and we give insulin and growth hormone subcutaneously from outside. So again, growth hormone has also to be given as injections, injected subcutaneously. So remember, it is not to be given intradermally. So many of the people, what they do is, they would give it like, very just parallel to the skin or with slight angle only. So preferably 45 to 90 degrees angle, you have to inject your needle so that it goes subcutaneously, below the skin. It is not intradermal. So if there is a ballooning that happens on the skin after you inject, that means it is being given intradermal. So always make sure that is happening. You are giving it subcutaneously. You have growth hormone, which can be given daily. You have growth hormone now, which can be given once in a week also. Once in a week growth hormone right now is approved for growth hormone deficiency. So for the other reasons, we still prefer to give daily injections. Pen devices, syringe devices, remember the medicine is the same. It is just the technique which is different, right? So here you're going to dissolve your powder with the liquid and then inject. Here you can, it's there in the pen itself, and then you do the mechanism and then you inject. So both the medicines are the same. It is the pen device or the syringe device, and therefore the technique which is slightly different. We usually prefer to give it at bedtime to mimic the normal physiology. And as I said, long-acting growth hormone is also now available. Somebody was asking me that if there is a redness at the site of reaction. Now, remember, local site reactions are quite rare. So always make sure that anything underlying is first ruled out, right? But in spite of that, say sometimes, if somebody is applying a spirit swab, that could be causing the reaction. So if the site is absolutely clean or you have washed that area, applying the spirit swab is not a compulsory thing. So sometimes kids do develop rashes. Sometimes somebody uses those sanitizer thing, just sanitizer, cotton, say big, okay, they use it to clean the area, and that might be giving the rashes also. Rarely it could be one of the constituents of the growth hormone preparation. And if you find that this thing keeps on happening every day, then you might want to change the brand to see that, whether it was that particular brand which was causing the local rashes or the redness of skin or not, right? Sometimes, what I have again seen a very common mistake is when we ask to take a pinch, the pinch is more tight and painful than the injection itself. So you just have to take a light pinch to lift the skin, not like a very tight pinch, because even sometimes that causes a rash. Another thing, once you inject the needle, don't push the whole thing down because it's not going to go any further down. You're just going to cause pain at the site, on the skin. So once you have injected the growth hormone, you just have to push it from here rather than pushing the whole thing inside, right? So these small things have to be taken care of when you give any subcutaneous injection for that matter. Safety and adverse effects. Now, remember, if you're going to Google, you are going to get a big list of the adverse effects. Remember, the safety profile also depends on the condition for which growth hormone is being given. So if you're giving growth hormone for somebody who has just got a pure growth hormone deficiency, you give it for years together, nothing is going to happen. There are certain conditions which might get exaggerated if they were there already and you have missed. Say, if you have had a bony deformity or a scoliosis, growth hormone is going to lead to growth of everything. So then that scoliosis might worsen, right? So it would be worthwhile to rule out these conditions before you give growth hormone therapy. Otherwise, remember, growth hormone therapy is a very, very safe and effective treatment. So if all the checkpoints have been checked and you have been seen by pediatric endocrinologists who say you need growth hormone therapy, I think we should not hesitate a lot because especially in the girls, we've got a very small window of opportunity left. The most common side effect that we do see in practice is headache, right? Which can happen because of fluid retention, which can be reversed by either decreasing the dose or stopping growth hormone for a couple of days and then beginning growth hormone at a lower dose. But then that side effect does not happen again. Glucose intolerance and diabetes mellitus, remember, there has been no frank case of diabetes reported because of a growth hormone treatment. But per se, in kids of Turner syndrome and SGAs, they have an increased risk of developing the metabolic syndrome later in the life, right? So again, remember regular monitoring. So we would do a fasting blood sugar and HbA1c on a regular basis when somebody who is on growth hormone treatment. Skeletal changes, growth hormone leads to rapid growth of everything. And that can sometimes lead to a slipped disc in your femur. And then the child can come to you as a limp or knee pain. But again, we haven't seen this practically in our practice. But yes, it would be worthwhile to make sure that the child is otherwise well. There is no kyphosis, there is no scoliosis, no spinal deformity also before you start growth hormone treatment. But otherwise, I would be very safe in saying that it is a very safe molecule. There are certain kids who will respond poorly to growth hormone. Deepa, do let me if I'm overshooting my time.
No worries, doctor. You can go on.
Yeah, I've just got a few more slides left and then I'll be done. So some kids may poorly respond to growth hormone, and that could be because of a variety of reasons. Since it's a costly therapy, we have seen kids taking growth hormone thrice in a week instead of the all 7 days. And that could be one of the reasons why they do not respond. So always check for the compliance. Any coexisting disease, say you're managing your CKD correctly, if that is not happening properly, the growth hormone will not respond as well. Existing hypothyroidism. So we saw in the earlier slides, thyroxine is also a very important hormone for the growth. So if you're missing hypothyroidism, so again, we would be screening out everything before we start somebody on growth hormone treatment. If your bones have already fused, your growth hormone is not going to work, right? Sometimes if there has been conditions where spinal irradiation has happened, as a part of your tumor management, then that is not going to grow. And we do not want to give growth hormone in those kids. Improper administration, especially with the pen form, you inject and then you immediately remove the pen. all the drops are going to come out. So you're not giving the complete dose. So especially in a pen, once you inject, hold the needle inside for 10 to 15 seconds before you bring the needle out so that all the growth hormone goes inside the body. Simultaneous steroid therapy. Now, a lot of the kids of this group might have CH, and you might have been advised growth hormone because CH kids do tend to go into precocious puberty. They might have an already advanced bone age. The precocious puberty is causing again more bones which are advanced, right? So sometimes if the doses of steroids are too high, then also the growth hormone response may not be as adequate. And if you have not done your test, and in a rare case of growth hormone resistance, growth hormone treatment is not going to respond. So you have to rule out everything. And I think this is the job of the clinician. But as a parent, we can be aware of these things. So, at least on your part, we have to make sure that we are compliant. We're going for regular follow-ups and checkups. We have to make sure we're giving the growth hormone correctly. When do we stop growth hormone? The child has reached an acceptably social height. Remember, on growth hormone treatment, we do not aim to make them tall, right? But a socially acceptable height, we can stop growth hormone. Or your child is now faltering, so bones are getting fused, so the child is not growing as well. Then you would stop growth hormone. Or as we talked, that if the bones are fused, there is no point in giving growth hormone. So then we should not further continue. So these are the 3 places where we would stop growth hormone treatment. So to conclude, growth hormone is definitely a wonder drug, when, if used judiciously for a correct indication with the proper dose and started at the right time, it can definitely give you wonderful results. So I think there are certain myths about growth hormone treatment and certain worries in the minds of the patient also when they start growth hormone treatment. I would just like to correct a couple of these myths before we have a Q&A. Growth hormone causes early puberty. That does not happen, right? But say you have a kid who is SGA, or you have a kid of IUGR whom you're putting on growth hormone treatment, those kids, by their nature of the condition, have a tendency to go into early puberty. So it is not growth hormone which is causing early puberty. It is the nature of the condition which is causing early puberty, right? So this is a myth that growth hormone causes early puberty. Growth hormone does not cause kidney damage. I don't know, we get so many patients with these queries, especially thyroxine and growth hormone. People are worried that they'll cause kidney damage. Remember, in patients of kidney damage, growth hormone is an approved indication, right? So growth hormone does not cause kidney damage. It is a very, very safe drug in matters of kidneys. It does not cause cancer, right? Say you have a patient of a pituitary tumor. The surgeon has operated, but they have not been able to remove the whole tumor. If that status remains the same for a year, you can give growth hormone to those patients also, right? So growth hormone does not cause any cancer or tumors, but there are certain tumors which have, by their own nature, a chance of recurrence, right? So that is why we have an extra caution. We usually want to wait for a year before we start growth hormone to make sure that whatever the disease state is, that is stable. We would be checking, monitoring very strictly in those patients, but growth hormone per se does not cause cancer, right? Again, there are certain conditions which are more prone to develop a cancer in the future. So it is not because of growth hormone, but because of the condition per se, right? Growth hormone causes disproportionate growth. So growth hormone is going to act on the whole body, right? But say if you're using it on somebody who has got a skeletal dysplasia, wherein they already have a disproportion, right? They have got short limbs, a bigger trunk, then the disproportion may increase, right? But if that disproportion has been ruled out, right, then growth hormone does not cause any disproportionate growth. The child will grow in its own proportions. So there's nothing to worry about that. Growth hormone is a steroid. It will cause excess weight gain. It will cause the girls to bulk up. That is not going to happen because number one, growth hormone is not a steroid. Your steroids, your hydrocortisone, your prednisolons, right? It's not going to cause excess weight gain. It's going to mainly work on your height. And for the girls to bulk up, they need testosterone. not growth hormone. So I have growth hormone, you have also growth hormone, we have not bulked up, right? And remember, all the doses, there is a spectrum to prescribe growth hormone. So we usually start with the lower doses and then increase the dose only when we need, right? So again, we would be monitoring for your side effects, and certain tests, bone ages, and the most important thing is, again, your growth chart. So I hope these are clear to you. And if you have any doubts and questions, let's look at those.